So we are talking about the cornea. So I'll start with the lecture on cornea, and I'll begin it with some investigations that we should know. I'll just name a few. I'll just name a few of investigations that are very essential for us to understand uh, the cornea. And these investigations, they might be seen when we are using or when we are talking about a particular disease or the disorder. So the first very important test that I want to talk about is keratometry. I'll just explain a little bit about it. I won't write much because of the fact that it's not very important for us to know the test in the beginning, because we could look at it directly when we are seeing the diseases as well. So the first that I want you to know about is keratometry. Keratometry is simple. It measures the corneal curvature. It's simple that the anterior surface of the cornea acts as a convex lens. So definitely the image is going to be inversely proportional to the size of the curvature. Greater the curvature, smaller is going to be the image, right? Correct or not? So the image is in the form of keratometric Myers. So now let's say you have a device, and this device is basically putting an image or throwing lights on your cornea. So you're going to have a keratometric Meyer, which is very important. So basically you would have three circles, and each of these circles would have a minus, positive, and a minus, a positive, a negative, and obviously in the center here a positive too. And again here you would have a negative plus a negative. How do I remember? I just remember negative is going to be on top and positive is going to be on the side. Alright, it's just simple as that. And this is your normal keratometric Meyer. If let's say one of these are separated, or let's say you, instead of having a negative, all of these signs are very important. For a matter of fact, instead of having a single negative, you have a double negative, or let's say you have a triple negative, or let's say you have a double positive. Any of these are incorrect Meyers, and therefore that can just help you with a little bit of diagnosis of astigmatism, whether it is with rule astigmatism, against rule astigmatism, stuff like that. And obviously it measures the corneal curvature. It also helps in deducting keratoconus, which is basically when your cornea has something like this, it's basically forming a cone. Second we have is pachymetry. Pachymetry measures corneal thickness. Normal corneal thickness is 540 nanometer, and it actually increases from the center to the periphery. So basically out here it's going to be maximum, and it's minimum, it's going to be maximum at the periphery. We say 0.5 or 0.6 millimeter usually at the central corneal thickness. That's what we are taking. So pachymetry is important because you want to do a LASIK. If you want to do a LASIK, let's say you want to do a LASIK, you want to test the corneal thickness, so that you know that you cannot get a particular LASIK done. Also, because if there is a certain increase in IOP, you want to know if it is because of the increased corneal thickness, or is it just because of the increased intraocular pressure. And the idea is that 1 mm of intraocular pressure is directly proportional, or 1 mm of corneal thickness is directly proportional. 1 mm Hg of, my bad, 1 mm Hg in terms of mercury of IOP is directly proportional to 10 micrometers of corneal thickness. Correct. So that's very important. The second that we have is corneal topography. To understand the corneal surface, we have placebo discs. They are basically circular pan like stuff which has an alternating white black appearance, and its reflection is seen on the eye or on the cornea, and basically you could see if there is a particular induration. So this, let's say there is an induration. All right, if let's say there is a particular induration, obviously that one spot will be left like this. Here there's an induration, basically that. Then there's something called as an OPScan. Then there's something called as a pentascan. So pachymetry, let me just write placebo disc, and OPS, ABCD, and OPScan. Again, corneal thickness and topography. And you have one of the best, that is the pentacam. What it basically does, that it measures your corneal topography, it measures your corneal thickness, topography, and your thickness, and also elevations in your anterior surface, elevations in the posterior surface, etc., etc. So it's very important. It uses the principle of split cam basically. So it's very important, pentacam on all of these tests. Now the other important test that we have is staining. Well, these were the tests that we did for corneal thickness and topography and corneal curvature and stuff like that. But what about when you're looking at when we are looking at especially uh, the cornea? If there's a particular denuded area, or let's say there's a abrasion or skin broken, the epithelia of the cornea is broken. So what about that? So for that we use stains, and we use stains like, first we use let's talk about certain stains. Let's say we use a fluorescent dye. So first let me talk about the fluorescent dye. You want to check this under cobalt blue light, and it's gonna appear green, like most of those movies that they show that when you use any UV light or a blue light, it appears green, similar, just stuff like that. And why would you use it? You would use it to detect a corneal ulcer. Also, you could use it for Goldman's applanation tonometry. Tonometry is basically a test to check the IOP, intraocular pressure. Or you could use it for Jones dye test, or Seidel test. Now your Jones dye test is for lacrimation apparatus damage. All right. And your Seidel test is basically a penetrating trauma. How will this help in your lacrimation apparatus? Basically, it goes into your tears, and you could just see if there is a damage of the lacrimal apparatus. Correct. This is a fluorescent dye test. Then you have the rose Bengal test. See, it is more rose Bengal. That means it's yellow, red, pink. Rose Bengal, come on, it has to be red. It stains the devitalized or necrotic tissue, and it stains the margin of ulcer. Next test that we have, actually it can lead to lead toxicity. This is rose Bengal test. How do I remember? See, in Bengal, there is a lot of guns. And it leads to lead toxicity. That's how I remember, because guns has a lot of lead in it. A stupid way of remembering. Fair enough. Let's me work in MCQs. Lissamine green test. I find this is the best test because it's non-toxic to healthy. It can also be used in dry eye by checking the conjunctiva, and you want to check for stippled appearances. All right. And last is your Alcian blue. And now we've studied from pathology that Alcian blue is something that stains the mucosa. So it obviously, or the mucin in the mucosa. So if it's going to stain the mucin, obviously Alcian blue is going to be staining the mucin in the cornea too. And that's how we can come to know if whatever pathology that it has. That being about the test, I would just want you to say it with me without looking at it. First is going to be your... Let's not give a lot of importance to order. Let's go to pachymetry. Pachymetry is going to be a corneal thickness. Also, you could use keratometry for astigmatism. You could use a very important thing called as op scan or a placebo disc, and you could also use a pentacam. Coming to stainings, we have fluorescent stain, we have rose Bengal stain, we have lissamine green stain, and then we have the Alcian blue stain. That being about the tests. Now we come to the most important things about corneal ulcers. Cause corneal ulcers are common. Right, they are common, and there is no doubt about it. So what is the most common cause in the world for a back? So ulcer can be obviously, I'm sorry to rush into this, but a corneal ulcer can be obviously a bacterial ulcer. It could be a viral ulcer. It could be a parasitic ulcer. Correct. It could be a fungal ulcer. It could be a viral ulcer. So so in this lecture probably we'll try and cover the bacterial and the parasitic or the fungal ulcer. Okay, so we'll cover the bacterial and let's say the fungal ulcer. All right. So the bacterial ulcer, the most common cause is going to be Staphylococcus aureus. So I'll just write SA is going to be the most common cause in the world. But what about in India? In India, it's going to be pneumococcus. That's basically Streptococcus pneumoniae. Okay. So what are these ulcers looking like? What do these ulcers actually look like? So basically, these ulcers, they have an ulcer serpent-like appearance. Ulcer serpent-like appearance. Let's say this is the cornea and this is your pupil, so it has an ulcer serpent-like appearance. And obviously, because there is going to be pus involved, there's going to be an infection, there's going to be pus in the anterior chamber, so we call it hypopion corneal ulcer. The most common cause of bacterial corneal ulcer in contact lens users, definitely you need to remember is, let's say if I write contact lens, you have to remember is going to be Pseudomonas, because there's going to be a green discharge. Most common cause of bacterial corneal ulcer in patients with a prior history of LASIK surgery. Let's say you get a LASIK done. All right, if you get a LASIK done, obviously your corneal thickness has been reduced, so you have an increased chance of getting a ulcer. So you have an atypical mycobacterium. All right, interesting. And what about the next? What about some other important things when I'm talking about a particular bacteria? Let's say if you have an infection about the nocardia bacteria, nocardia, it causes wreath-shaped ulcers. So basically, if this is your cornea, you would have an ulcer that is something like a wreath shaped ulcers. And if you want to talk about bacteria that directly invade the epithelium, then that can directly invade the epithelium and do not need a complete breach in the epithelium, so then the name goes as Neisseria, Corynebacterium diphtheri, Listeria, alright, Listeria, Shigella, and Haemophilus. Shigella, Haemophilus, Aegypticus. So this is the list where it does not need a breach. All right. So that's just giving a very brief overview. Now we can directly get into the details of it. So what is an ulcer? An ulcer is basically discontinuity in the corneal epithelium at cellular infiltration and necrosis of the underlying skin. So there's a discontinuation and there's going to be infiltration and there's going to be necrosis out here. There's going to be necrosis. This is a corneal ulcer. So first of all, what could be the causes? What could be the predisposing factors that could lead to a corneal keratitis or a corneal ulcer? First of all, obviously, keratitis. There has to be a breach in the corneal epithelium. Obviously, here there's going to be a breach in the corneal epithelium. That's the first thing that's seen. Or there's going to be a corneal abrasion. There's going to be a corneal abrasion. Or there's going to be epithelial drying. There's going to be epithelial drying. So because of that, your goblet cell and the mucus has been decreased. So it's obviously you could see it in xerosis, or you could see it in keratomalacia, where there is a little bit of change in the squamous epithelium that is present in the epithelium of the cornea. So that could be due to keratomalacia, or you could be desquamatization of the epithelium, again due to bullous keratopathy, or probably any of these disorders, right? So there could be damage to the nervous systems of the cornea, which is obviously leading to corneal anesthesia and therefore increased damage. All right, so straight up, that this is going to be a very important cause and disease, right? These factors that could lead to these ulcers. So now, before getting into what each of these bacterial ulcers and each of these bacterial ulcers are, how do you know, how do you identify, again revising upon that, I would like you to understand the pathology or the pathophysiology, not pathophysiology, but obviously the pathogenesis of the bacterial keratitis. So what happens is that first of all, first stage, you need to have a ulcer. you need to have an ulcer. Obviously, you need to have a saucer-shaped ulcer with an initial overhanging margin, bacteria adhered to the cornea by proteins and toxins, and then there is infiltration. Here, your bacteria have adhered, and there's going to be definitely there's going to be an ulcer with a overhanging margins. Here, your bacteria is going to adhere, and there's going to be some amount of necrosis out here. There's going to be sloughing of cells. There's going to be a lot of sloughing of cells, not just a little bit. There's going to be sloughing of epithelial cells, and let's say even your Bowman membrane might be damaged. If the Bowman membrane is damaged, then we call it a deep ulcer. Obviously, if it's not damaged, it's called a shallow ulcer. Now, stage 2 is when you have a progressive stage, when let's say you have an infiltration of, so let's say now because of cornea is relatively avascular, but now because of this you have certain amount of infiltration of blood, and because of that, let's say not blood but probably definitely your neutrophils, and your neutrophils have been infiltrated, not yet the blood has reached, but definitely your neutrophils have infiltrated, and because of that you have certain amount of pus that's getting formed in the anterior chamber. Obviously, I would love to remind you that this is the anterior chamber. All right. I'm sorry, my bad. We are looking at the cornea that is present here out. So let's say if this is the damage, your let me so this is the cornea, all right, and basically we are looking at the damage done here. All right, this is the cornea. We're looking at the damage done here. So there's going to be a lot of infiltration, and the pus is going to move directly inwards into the anterior chamber to cause hypopyon. All right, or the liquid like pus, and the pus is going to be sterile. It's not going to be pathogenic. That's very important. And this hypopyon moves with a tilt of head, and it's not very thick. It's liquid like, and hyperemia occurs of the circumcorneal vessels. So let's say this is your eye from the anterior view. All the vessels, that is the circumcorneal vessels, they are going to show certain amount of hyperemia, and there's going to be exudate on the cornea, on the surface of the cornea. Also, what we are going to see is that because of the transfer of infection to from the cornea to the anterior chamber, usually it's sterile, the pus, but definitely the inflammation can pass on to the uvea, and the iris, causing keratouveitis, and that is a very important complication which you can see further. But stage 3 is going to be after this stage, after your neutrophils have infiltrated. Obviously, next what you're going to think about is you're going to have certain amount of regressive stage. For example, your causative agent has to be eliminated, right? It has to be eliminated by the cell mediated or humoral immunity, and there's going to be superficial vascularization. As I told you, there has to be vascularization, obviously. So there's going to be certain amount of vascularization, superficial, probably not deep, obviously. That increase the humoral and cell mediated response. And when there's vascularization, there's certain amount of healing. Note, if the Bowman's membrane is damaged, definitely there cannot be healing of the Bowman membrane. But definitely healing will occur in any case, and a scar might remain. So if the healing has occurred because of cell mediated humoral or whatever immunity, and then there's healing, all right, because of reepithelialization and progressive fibrosis, and there is fibrosis by the keratinocytes, fibroblasts, and by the endothelial blood vessels that are going to proliferate in that region. There is going to be certain amount of fibril thickening. There's going to be more stroma. Let's say if this is the side of the ulcer, and now the ulcer's gone, so there's going to be certain amount of increased trauma, and because of that, there's going to be pushing of the epithelium a little anteriorly. Correct. But and if the Bowman membrane is, let's say, damaged, which cannot heal, so it's like an irreplaceable layer, there's going to be three types of scarring. There's going to be nebular scarring, there's going to be macular scarring, and there's going to be leukomatous scarring. All right, so this is going to be the pathogenesis of your keratosis. Now the question comes, what are going to be the complications of this entire event? First thing that you need to understand is ectatic Cicatrization means healing. Ectatic means bulge. Ectatic, cicatrix. Basically, ectatic means bulge, cicatrix means healing. So, ectatic means due to healing, your cornea is going to bulge. Why? Because during healing, certain amount of fibrosis has occurred. Also, your cornea is not the same as it was. So there is certain amount of thinning in probably there is certain amount of thinning as well, because of which, if there is increased IOP, there is going to be a bulge. Second complication is anterior staphyloma. What does that mean? Staphyloma, my dear friends. Staphyloma is literally nothing but when the iris is bulging along with the cornea. So basically, what happens in this entire situation is that when there is a corneal sloughing, basically loss of corneal epithelium, there is also a prolapse of iris. The iris becomes inflamed and exudation occurs, which blocks the pupil and covers it. Alright, first you hear it, then I'll explain it. When a virulent organism causes corneal sloughing, there's going to be corneal sloughing. Okay, there is a prolapse of the iris. There's a prolapse, as in the prolapse will be out here. Why? Because the iris becomes inflamed. Obviously, as I told you, keratouveitis can occur, and exudation occurs, which blocks the pupil and covers the iris. Alright, there is a false pseudocornea formed, and the pseudocornea is thin and cannot withstand the IOP, which is why the cornea, with its prolapsed iris, bulges. Okay. So what happens is that because of an inflammatory reaction, your iris is going to stick to your cornea. Normally, your iris is this. But now what happens is that your iris is sticking to the cornea. And there's going to be a bulge of the iris on the cornea. And why does this all occur? Is because exudation has occurred. Alright. There is an exudation which blocks the pupil and covers the iris. Alright. And it forms a pseudocornea. What is a pseudocornea? Basically, let's say if there's an ulcer in a particular region. Alright, let's say this is your cornea, this is your iris. Alright, this is your ciliary body. And I just the head part. It looks very different. Does not look like an eye. It's not an anatomically correct diagram. Correct. So let's say if there's a ulcer here. Let's say there's an ulcer. So what's going to happen is that this is going to be your cornea. This is because of the exudation, because of the sloughing from this area. Some of the sloughing is going to reach the iridocorneal angle. And at the iridocorneal angle, there is going to be certain amount of exudation, correct, that has reached. And because of that, there is going to be certain amount of adhesion, correct. Because of the adhesion, the iris gets plastered along the cornea, and the iris is plastered along the cornea. Let me make the iris in the green. The iris is plastered in the cornea. From where it was and where it holds the lens to what it has become, the pupil. Alright, the pupil was initially open, but now what has occurred is that this is again not the anatomically correct diagram. Let me make it even better by refining the diagram. Is that your staphyloma is going to block the pupil by causing an adhesion. So if this is your iris, it has moved forward and it has caused an adhesion, because of which your pupil is blocked. Now when your IOP, intraocular pressure, because your fluid is formed here, and there is no way of going out, correct? When this block has occurred, when the IOP increases, it goes out, and when it goes out, it forms a descemetocele or a perforation of cornea. So what happens is that whenever there is increased pressure, the cornea may bulge out. The decimate membrane, let's say if there's a shallow ulcer, the decimate membrane will bulge out. But if it is a deep ulcer, the anterior staphyloma may occur, or there can be even an aqueous leak, because whatever aqueous humor, let's say, is present in this area will definitely leak, and there is going to be an iris prolapse. There's going to be an iris prolapse along because of the anterior staphyloma, and there could be a descemetocele. Let's say if this is your cornea and this is your epithelial damage and this is your basement membrane, the basement membrane will project outwards and it will form a descemetocele, and therefore definitely you will also see certain amount of pseudocornea. Pseudocornea is nothing but the iris forming as anterior staphyloma, corneal surface formed by perforated iris tissue, something called as an anterior staphyloma. And the last complication could be if there is further inflammation. If there is further inflammation, there's going to be endophthalmitis or panophthalmitis, and that is going to be the further complication. All right. Now we can talk about certain things like hypopion corneal ulcer. What is hypopion corneal ulcer? Hypopion corneal ulcer is the most common bacterial ulcer that is seen by pneumococcus. What is seen by pneumococcus? Pneumococcus is the most common cause of bacterial ulcer. It starts as an ulcerous serpens. It then goes on the pus to form an hypopion. What is the sources? Obviously, it comes from a chronic dacrocystitis. Dacrocystitis basically means inflammation of the lacrimatis apparatus. All right. Now the question is that the ulcer serpens, all right, it has a tendency to creep over the cornea and cause an hypopion, the ulcer. Basically, the ulcer is expanding and it causes the hypopion. Now, the complication of corneal ulcer is that obviously I told you there could be iridocyclitis, there could be ectatic scatters, there could be secondary glaucoma. Why could be the secondary glaucoma? I forgot about that. As I told you, because of this anterior staphyloma, your iridocorneal angle, this angle has been narrowed. If you see this angle is very necessary for the intraocular pressure to be reduced by aqueous humor outflow. There are two types of aqueous humor. One is the trabecular meshwork outflow and one is the uveoscleral outflow. The uveoscleral outflow is the majority pathway of the outflow. Now, because of the narrowing of the angle, there is going to be less outflow of the aqueous humor, and because of that, there is not going to be enough outflow, and that is going to cause a secondary closed angle glaucoma. I mean, if you want to talk about the angle, obviously the angle has been closed, and definitely it's going to be closed angle glaucoma. Talking about other complication is going to be descemetocele. Descemetocele is descimate membrane herniation. Perforation of the cornea is going to lead to prolapse of the iris, is going to lead to pseudocornea, it's going to lead to anterior staphyloma, and more importantly, it's going to lead to something called as the anterior dislocation of the lens. And it's going to also cause the endophthalmitis and can also lead to intraocular hemorrhages. Now you would ask me, what is the management, or what is the sign? And first let's talk about the sign and the symptoms. If a patient comes to you, what is he going to complain of? He's going to complain of, first things first, he's going to complain of pain. He's going to complain of foreign body sensation. See, this is not an anesthetized area. He's going to complain of watering. He's going to complain of photophobia. Is he going to complain of halos? He's not going to complain of halos. Because halos is only seen in conjunctivitis, glaucoma, and cataract. So he's going to definitely see blurred vision. He's going to see blurred vision, and he's going to also see swelling of eyelid. He's going to be blepharospasm. What is he going to see? Blepharospasm. He's going to see blepharospasm or twitching of the eyelid. Also, he's going to see certain amount of chemosis and hyperemia of the conjunctiva. He's going to see hypopion. Now, these will go into the signs. We're going to see a hypopion. But definitely, he's going to have blepharism. Blepharism. Why is there going to be a blepharism? It's going to be a blepharism is just an intense twitching of the eyelid. There's going to be twitching of eyelid because of the foreign body sensation that can be present, correct, as a result of the corneal ulcer. Now, because of that, we are going to have all of these different conditions or signs. And the signs are going to, and when you look at the ulcer, definitely your cornea is going to appear a little bit of circumcorneal hyperemia is going to be seen. And there's also going to be a lot of chemosis of the cornea. How do you want to treat it? You want to treat it by using fortified antibiotics, and you want to use fortified antibiotics, important ones, that can target your gram-positive pseudomonas, or gram-negative pseudomonas, and a gram-positive pneumococci and Staph aureus. Now, your pseudomonas is going to show a green mucopurulent discharge, and that is going to help you diagnose a hypopion ulcer perforation. Alright, exudate. But your nocardia is going to show a wreath-shaped ulcer. But E. coli or Klebsiella produces a gray ring-shaped ulcer. And Staph aureus and pneumococcus have dense and opaque ulcer and normal hypopion, sterile fluid hypopion. You want to use antibiotics, you could use cefazolin, you could use tobramycin, and you could use vancomycin. We also want to use for the very important reason that we want to use atropine is that it is going to relieve the ciliary spasm that is occurring in reaction to the iridocyclitis that has occurred due to the inflammation that has been passed on from your corneal or keratitis. Now, your ciliary spasm has to be inhibited because your ciliary spasm is going to put a lot of strain in the eye. And atropine is also going to relax the blood ciliary body, because of which the anterior blood supply to the anterior ciliary artery is going to increase, and there can be quicker resolution because of humoral and cell-mediated immunity reaching that particular area of the cornea. Steroids are definitely contraindicated. I do not need to tell you, because it thins the cornea, and if there is an impending perforation, we want to give glue. We can give a cyanoacrylate glue. We could lower the IOP. Now, coming to a very important second thing that I told you we will cover in this lecture is called as a fungal ulcer. What is a fungal ulcer? A fungal ulcer is simple. It is mostly by Aspergillus. Which is a filamentous fungi with septate hyphae. Aspergillus is a very dangerous fungi. It has a ABPA, Aspergillus bronchopulmonary allergic syndrome. It has so many different disorders. But what is important to note in an Aspergillus is that the patient does not feel any pain. Like, he has lesser pain than his symptoms suggest. What do you mean by that? So the thing is, doctors, that we have to note as doctors that these patients that come, when they give as a very classical history of steroid use, of antibiotic use, and they give a history of certain amount of damage by vegetations, we want to look for a fungus like Aspergillus. Obviously, this is the most common cause, but you could have other causes like yeast. You could have histoplasmos histoplasma, or you could have coccidiosis or blastomycosis. We could have a lot of disorders like these. What is the very important the very important factor that you should think when you're looking for signs? What are the signs that you should check? The first signs that you should check is the ulcer should be dry looking ulcer. The hypopion should be thick. It should be immobile. There should be a feathery margin of ulcer. And along with the main ulcer, you can see side lesions of the ulcer. So there is a feathery margin of the lesion of the ulcer, and there's going to be side lesion or satellite lesions. And the most important is that you should be able to see a Wesley immune ring that is present around the feathery margin of the ulcer. Obviously, you cannot say that there is going to be a Wesley immune ring very easily. You need to see certain amount of eyes and certain amount of clinical practice to understand the eye. But what is going to be the symptoms if the patient comes to you? Obviously, he's going to have photophobia, blurred vision, watering, redness, and all of that. But can you tell me that, let's say we're considering all funguses, but let's say if there is a particular fungus that I'm talking about Candida. Candida, yeast like Candida. So if there is a Candida, what happens is that if there is a cornea, under the stroma, you're going to have a yellowish white stromal infiltrate in case of Candida. That is the only differentiating factor. But if the ulcer is, let's say, brown, then you might have a dematicious or a black fungi. That is again not very high yield. What is high yield is now the treatment. How do you want to treat it? Obviously, you want to use natamycin. What is natamycin? Natamycin is a 5% eye drop that you want to use for aspergillosis. Or you could use amphotericin B. Obviously, that is a wonder drug that is given if Candida of anything. And obviously, you want to give your atropine as a supportive therapy because you don't want the pain and stuff like that. And if you want, you could go for systemic antifungals depending on how bad it is. And you want to use azoles for that. Correct. And let's say if you use intracorneal impairment and stuff like that, you want to obviously go for voriconazole, ketoconazole. Actually, you do not go for ketoconazole. Ketoconazole has its own side effects. Now, ketoconazole is more or less outdated. We've got better drugs like fluconazole, we've got voriconazole, itraconazole, stuff like that. So definitely, this is the entire thing about, as far as I could cover, about ulcers, corneal ulcers. And we will talk about the other stuff later.